100 people a week, trying to get anyone who is eligible, interested in coming to San Francisco General Hospital at UCSF or going to the Northwestern Medical Center in Chicago. And we were able to do blood tests, glucose tolerance tests, coronary calcium CT, ultrasound of the carotid arteries, and EKG at that visit. It was a 4 to 6 hour long visit, and we asked 52 pages of questions. Oh my God, these people were amazing in doing the whole, phenotyping that we did at exam 1. And then every year since then, we've been in contact with them by phone or email, asking them to complete a very short 5-minute questionnaire about has there been any hospitalizations, any procedures, any diagnostic tests, any events. And if they say yes, then we ask them to release their medical records to us. We get the records, and then we centrally adjudicate if they've had a stroke, a heart attack, etc., because that is one of our clinical endpoints. We got a separate grant in 2014 to map out social networks, because again, we really want to take a very broad look at this community, not just all molecular or biologic, but we really want to look at the environment, the social structure of their life, to understand what is modifiable, what is actually preventable if there are risky behaviors or risky things that they may be doing for their health. And so we did that. And then this was the last wave of data collection where we brought everybody back who was surviving and still living in these areas to repeat glucose tolerance tests, the CT scan, so we have some prospective data on CAC change that I'll show you. And then we got a nice small philanthropic gift from a donor who allowed us to actually expand the cohort with another 250 participants, and Zubeida was so helpful in helping us enrich the cohort with more South Asians, especially from other countries except not only from India. And so right now I'm writing grants, fast and furious, trying to get exam 3 funded, hopefully to start next year. And so here's where I'm going to go in my 20 minutes or so. I don't want to speak too quickly, but I do want to engage you in conversation. So if you want to stop me to ask clarifying questions, that would be great. And we'll save some time at the end for bigger discussions. Okay? So I'll show you their characteristics, and then their type 2 diabetes rates, and then the atherosclerosis data that Hattie and Nirali have really asked me to focus on as the captain. What are some of the health policy implications so far from this pretty young cohort? So most of the people in the cohort are immigrants, and that's largely because of the U.S. immigration waves that started primarily in 1965. You can see 84% are from India, 2% are from Fiji, and 2% were born in the U.S. And you can see the other South Asian countries that are represented in the cohort. So this is pretty similar to the U.S. Census. There's more Pakistanis. It's closer to 9% in the last census. So we're a little low on Pakistanis. Nepalis, Bangladeshis, Sri Lankans are still the small minority of the South Asian population in the U.S. And in terms of how long they've lived in the U.S., the average amount of years in the U.S. was 27, and about 50% of their life had been spent in the U.S. So there's a nice bell-shaped curve about early immigrants, people who've been here half their life, and then people who've been here a long time. So it's a nice way to actually look at acculturation. Now, those are really super interesting data that I'm not going to be able to get to with limitations in time. Socioeconomic status, this also parallels the U.S. Census, because the reason that there are so many highly educated and wealthy immigrants here in the U.S. is because of the immigration practices were only allowing people in the 60s and 70s especially to immigrate because they were coming for higher education and professional work. And so you can see the men in Masala, 64% have a greater than a bachelor's degree, 25% had a bachelor's degree, so about 80 to 90% are educated with a bachelor's degree or higher, and it's almost 80% women as well. Family income parallels that with a higher income than 100,000. So in the next few slides, I'm going to compare Masala in the first column, showing the South Asians, to the whites, African Americans, Latinos, and Chinese in Mesa, just showing you some of the easy kind of behavioral characteristics that we can ask people, to self-report. So very few smokers in our population here. which is as low as the Chinese 6% in Mesa. The Chinese population in Mesa, 96% are immigrants. So these are two Asian immigrant groups in these studies selected for the same reasons of not having cardiovascular disease. And so there's some similarities, but a lot of differences. The next thing was alcohol use is fairly modest for both of these Asian groups, and you can see they're higher among the whites, African Americans, and Latinos. Exercise was pathetically low among the South Asians, and this is measured not by an objective measure with accelerometry or steps, but with a questionnaire that's 4 pages long asking what type of activities they do, even leisure activities, as well as at work, at on the weekends, etc. Includes things like yoga, includes weightlifting, everything. And you can see that compared to the other 4 groups in Mesa, the South Asians have the lowest physical activity level, and that's a nice, easy, modifiable risk factor to just start working with. TV watching was also quite low. Now this is a question in that physical activity questionnaire that said how many hours per week do you watch TV, or how many hours per day, and then we calculated per week. Had they said how many hours do you spend looking at a screen, that may have been very different. So the question was TV watching, so it's quite low, but there's a problem with that question. Okay, so South Asian foods, everyone thinks this is a big culprit, and there may be good reason to think that way. It's very, very hard to measure South Asian food patterns, especially immigrant first generation South Asians who are still, eating a lot of the South Asian foods, as well as incorporating American food. So what we did was we used a food frequency questionnaire that was created and validated in Canadians, South Asian Canadians. And that's a big population of Indians, Bangladeshis, and Pakistanis who live in Canada. So it's a fairly good way to measure what South Asians in the US would be eating. 163 items, very painful questionnaire. All food frequency questionnaires have the same problem, that it's all recall bias. You have to remember what you ate over a year, and you have to be able to be accurate about it. So they're about 60 to 70% accurate. So we take that with a huge grain of salt. But it's one of the ways that epidemiologic studies do this. Now, we didn't use the same questionnaire as Mesa, so we can't compare across exact questionnaires because they had a very different diet question to ask. So what we found doing an analysis of all these items is there's 3 major dietary patterns that are consumed by the population in Masala. And it's almost a third of people predominantly eat either an animal protein Western type of diet, a third eat this middle fried snacks, sweets, and high-fat dairy diet, and then a third eat the fruits, vegetables, nuts, and legumes. So people always say, oh, so the fruits, vegetables, nuts, and legumes is the vegetarian diet. And then that middle one is probably, a little bit of both. Turns out that if you look at vegetarianism, and about 40% of the cohort is fully vegetarian, has been lifelong vegetarian. Half of the vegetarians are here, and half are here. So when someone was saying vegetarian diet, yeah, and how do I have heart disease risk? I really probe about the vegetarian diet if it's in this category, which is a very traditional South Asian, or maybe they're actually eating more of this, but then on the weekends they eat this. So, so I think that was, and then what we did was look at this and we analyzed it with all of our metabolic data, atherosclerosis data, and we found that it's the animal protein and this fried snack, sweets, high-fat dairy that were very associated with metabolic risk factors, with higher weight, bigger waist circumference, higher blood pressure, lower HDL.
Even the vegetables are cooked in, oil and stuff. And it's never like fresh, dry vegetables.
Exactly. So the FFQ actually asked about that, the type of, the way the vegetables were, if they were sauteed, if they were pan-fried, if they were curry sauce. So, and the recipes were, already calculated in terms of the macronutrients and micronutrients.
Very complex.
It's super complex. There is no easy way to measure diet. So I mean, this was a good thing to, just investigate in terms of, So probing about the diet, making the diets be more in the fruits, vegetables, nuts, legumes, which also included fish and chicken and other lean meats. That would be kind of the preferable angle. Actually, one question.
Where did the grains fit in, or were they kind of spread equally?
Whole grains.
Grapes.
Yes. Grapes?
Grains.
Grains. Yes, there were some in each. There were more grains in the healthy, the prudent diet. That was one of the major food groups in there.
In general, did you have an average of sugar that people consume?
It's actually very low in terms of like looking at NHANES and what the U.S. population consumes for sugar, like sugar sweetened beverages or added sugar to tea or coffee. Your sugar intake in South Asians is actually pretty low, but there's maybe a lot of sugar in the foods and the desserts and in the food they're eating. So just raw sugar is very, very low. Yeah.
But in general, when you calculate grams of sugar per person, including the desserts and all that?
It's pretty low. It's pretty low, yeah. The desserts are not on a daily basis in general, yeah. Very low on the non-Indian sweets like cakes and donuts and pastries, and we asked a lot of those questions, and pretty low consumption overall for desserts.
So if, just on a time check, we have 25 minutes.
Okay, good.
Including Q&A.
Okay.
So
Yeah.
we'll just, I
I'll
don't
make
should
it.
be stressed.
Okay, so am I
Yes.
speaking too fast? Sorry.
You're doing great.
Okay, so let's talk about body and body weight. And everyone knows the definitions of overweight and obese are different for Asian populations. We're not using this consistently in the clinic, and we should be. But this is, normal weight for an Asian should be 18.5 to 22.9 for BMI. Overweight should be 23 to 27.5, and obese is greater than or equal to 27.5. So when we looked at this in Masala, what we knew is that we expected the South Asians to maybe not be so heavy, but still have a lot of fat in their body. And so this paradox was described in the early 2000s, and this gentleman to the left is Dr. John Yetkin. He's a professor at Cambridge, and he has a BMI of 22, and his body fat is 9% when you use a DEXA scan. And then that's Dr. Yajnik from North India, same BMI, exactly the same, but his body fat is 21%. And you look at that man and you're like, there's no way this man is, yeah, but this is the problem, that there is fat. And so we were really interested in looking at this in Masala, like, is this really part of the problem that gets us in trouble? And so using CT scans, we did CT scans of the heart, CT scans of the abdomen, and got some muscle tissue in there, as well as liver and around the intestines. And we found, looking at these different areas, pericardial fat, intramuscular fat, fatty liver, and visceral fat, the bottom line is that South Asians, yeah, so South Asians store fat in all the wrong places. So this is looking at, CT measures of fat in these people, and South Asians are in yellow here, so that's visceral fat. And you can see this is one of the lures that I want to dispel here, is a lot of UK data has run with this, that there's a lot more visceral fat in South Asians. There's a lot of visceral fat in South Asians. I've heard that my entire life. There isn't actually that much more visceral fat compared to whites. It's very similar, but there is more than Chinese, Africans, and Latinos. Where there's a lot more fat is actually in the muscles and in the liver, and there's a lot less lean muscle mass. So it is a fat problem, fat in the wrong places, but it's not all about the visceral fat story. And I think the way visceral fat was first identified was with waist circumference in the UK studies from the 70s, where it was big waist, and that there's a lot of fat around there. But it turns out most of that fat's subcutaneous. It's not actually all visceral. And when you look at CT scans and MRIs, there's really, the visceral fat is not that out of place.
So where's the liver fat?
So this is liver fat. So it's a measure of hepatic attenuation, which is inverse. So lower means more fat in the liver. So liver fat really stands out.
So that's really visceral. That's what it is. Visceral mental is visceral fat, not what you have around.
Right. But liver fat is a different depot, not visceral. Right? It's measured in the fat in the hepatocytes. So it's fat that's within hepatocytes, not around the omentum. So I just want to make sure that everyone is, that this is actually a new meta-analysis that we've done with the UK Biobank data. They have CT scans now on 5,000 South Asians, and we've analyzed all the world's data, and it's definitely liver fat that seems to be kind of a big player in this whole game, which is fine. The distinction is important because I think there may be the ways that you actually can reduce fat in the liver or fat in the visceral area or fat in the muscles may be different. And I think any kind of weight loss can impact fat in the liver where it may not do anything for fat in the muscles unless you're doing other types of exercise.
And I mean, actually, we are in the middle of an epidemic of fatty liver disease in
Right?
America.
Exactly.
And this is the type of fatty liver that you're talking about.
Exactly. Non-alcoholic fatty liver disease, exactly. This is actually easy to diagnose clinically without CT scans, right? There's good surrogate markers of this. That's ALT. That's an enzyme test that you do on a metabolic panel. And a high ALT tracks really well with high fat in the liver, so you don't have to do imaging studies or expensive tests. It is an easily available test, and it tracks well.
Should we have a separate session another day on the relationship between high fatty liver and cardiovascular disease?
Yes, and there's very little data about that. There's really great new data about fatty liver and diabetes, but there's very little data connecting cardiovascular disease.
So maybe coming in just to that.
Okay.
Right, experts to lecture on that.
Okay, all right. So we did an analysis looking at people of normal body weight or normal BMI in our cohort. So this is BMI less than 23 in the South Asian. So this is looking at this part of the panel, normal weight. The red dots show you people who have metabolic abnormalities. So that's a glucose over 100, triglycerides over 150, HDL less than 40 or 50, depending on sex, and high blood pressure. So in the normal weight group, you can see that the red dot in the South Asians is higher than the others. There's more metabolic abnormalities. Almost half of the people with a normal BMI, this is BMI less than 23, have metabolic abnormalities. And so when we looked at this more closely, we wanted to say, well, what BMI would a South Asian have to not have high metabolic abnormalities? So for a white person in Mesa, this blue line, at a normal BMI, less than 25, so right at 25, there's about 30% prevalence of metabolic abnormalities. So what would the BMI be for a South Asian person? And when we model this, a BMI of 19.6 in a South Asian is roughly equivalent to a BMI of 25 in a white person. And you can see for all of the other race ethnic groups, for Chinese it was 20.9, for Latinos it was 21.5, African. So there was this big Newsweek article that says that, there's a racial bias with BMI. And I mean, I think that that's a little hyperbole, but I do think that BMI is a useless marker of adiposity because I've shown you that there is fat in the wrong places in South Asians, and that you can't clinically counsel someone to get down to a BMI 19.6 very easily, but that is where the risk starts to really go up.
I mean, I would, in my practice, I rarely see somebody in BMIs of 23 or 24.
They don't get up.
If I see a patient, heart patient, and it's a pretty skinny patient, and I look at the BMI, it's 24, 25, so it's getting to 19 is almost like,
Yeah.
it's not even close.
Yes.
Louisa?
I had a young woman recently who came to me with gestational diabetes on metformin therapy, who I counseled on getting the weight down, came back to me 3 months later with significant weight loss, BMI down to 19.
Awesome.
Completely normal metabolic profile,
Right.
off medicine
Right.
completely.
Yeah.
And the response, I congratulated her,
That's fantastic.
But the concern that was interesting of this couple was that I'm too skinny.
Yeah. Well,
And
it's
they
culturally.
were really afraid.
Does
of
anyone want to
being
explain
too
the
skinny.
cultural reason?
Okay.
Especially a woman who's just had a baby. Oh my God.
Oh dear.
Oh my God.
I told her this is great, but I mean, it's like she really thought that I would, it's like they were concerned that there was another
Yeah.
problem.
Yeah. On a side note, a colleague of mine at Kaiser, Permanente Asia Ferrara, did an intervention in women with gestational diabetes, and this is mostly like Asian, Latina women, African American women, to see if they could make them, change their diet and exercise while pregnant to kind of get off of insulin and have better birth outcomes. And the hardest group to make any change to was the South Asian women. And these are women in a study, motivated to be in a study, but there's such a cultural overlay in diet and activity, especially around birth and pregnancy and what a woman should eat to be healthy for the baby. Do I need to? Okay. So that's great that you got it down.
Do we know anything about, obviously have hepatic steatosis.
Yes.
Has anybody looked at this to see if this is longer chain fatty acids or more saturated, or is there cholesterol ester associated with it? The kind of things we really need to
So we have lipidomic data on the whole cohort now. We have metabolomic data on the whole cohort.
But from the liver?
No one that I know has
Anybody?
put needles in the liver.
You wouldn't have to do very many,
Yeah.
but it might be quite distinguishing,
Yeah, well, that could be.
something we might
There,
do.
there are people doing this in polycystic ovarian syndrome at UCSF, and I'm sure many of their cohort participants are South Asian women, so we could maybe partner with them.
Quick question.
Yeah.
So based on what you said, if we don't use BMI as a proxy for body
Yeah.
fat, is there a substitute that
Yes,
is
no,
possible?
I would just ignore it. So what I mean to say is a low BMI should just throw that out the window. It's not protective. So don't rely on a low BMI being like, oh, you're okay. You don't have to worry about your diet. It means nothing. A high BMI is something you definitely need to counsel about. Now, what is a high BMI? Is it over 19.6? Maybe.
What you're really saying is easier for us to predict disorder, but it's very difficult for us to predict health.
Right. Yeah. Well, the health, I think it does track with, the lower the BMI, the better. So that is kind of one question, is just because someone has a small body frame doesn't mean that they don't have fat or not. Yeah, weeks is, again, it's okay. It's very hard to do clinically, so I don't recommend it. We did a pilot study of, clinical measurements. It's so poorly reproducible. You just take a little breath in and you lost 2 centimeters. So prevalence of diabetes in Masala was about 26%. This is using fasting glucose and a 2-hour glucose tolerance test, and people who were already on medications. A third were pre-diabetic and 40% were normal. And I'm going to show you this complicated bar graph to compare people in MESA to our Masala participants. The first bar here for men, almost 30% had diabetes, and that's much higher than the other men in the other groups. Another 37 had pre-diabetes, so there's like very few with normal. But look at the women. The women in our cohort are much healthier than the men. About half the prevalence of diabetes in the women, 15% of the women in Masala had diabetes. A third had pre-diabetes. And you can see the women who were African American in MESA had more diabetes than the South Asians, but the South Asians were higher than the other groups. So
Can I ask you a question
Yeah.
about, do you think that metabolic distribution applies to the whole South Asian population, or do you think that is specific to your cohort?
You mean this distribution of the gender difference?
No,
or?
the presence of, actually 60% of your, 64% of your
Men, yeah.
cohort, of your men cohort, were this metabolic.
Yes.
Now, would you think that that is true for the general South Asian population?
So I just gave a talk this afternoon that analyzed the NHANES data for the last 6 years that have oversampled Asians. And we broke up the data by South Asians, East Asians, and Southeast Asians. We couldn't do it finer by nation. And what we found was the prevalence of diabetes in NHANES is 24%. The highest of any group is in the South Asian. So I do think that the overall prevalence we're seeing of 26% is pretty real.
And 37% for this
For men, yeah. So yeah, the pre-diabetes was similar too. But the sex difference that I want to show you, every single group has a sex difference, okay? So the men always have higher prevalence than women, and this has been seen around the world. And it's actually relatively new phenomenon. Since maybe the last 20 years, there's been a higher prevalence in men.
Is there data related to this and age? Did you look at
Yes,
age?
I'm not going to show it to you, but yes, it's higher with older age, for sure.
Okay, so at least, and is that the same thing with women? So,
Yes, older than
so
women.
age is not interfering, it's more.
Yes, I mean, yeah, so these are adjusted.
And were there other factors that you identified that could make a difference or generic?
Here you go. Thank you,
sorry.
you set me up. So here is, we basically adjusted for every single risk factor that we could, harmonizing MESA and Masala. So this is including education, income, smoking, alcohol, exercise, BMI, weight, HDL, triglycerides, hypertension, and fasting insulin. So when you control for every metabolic risk factor, that only made the differences more stark. So the prevalence was 26.7% in the South Asians. We excluded the people less than 45, just so we had very comparable populations, right? And you can see it was 6% in white, 16% in African Americans, 14% Latinos, 16%. So this is true, and now that I have the NHANES data, and then we also did an analysis with Kaiser data, same thing with the South Asian, so I believe this. This is real.
It's very powerful because when we talk about prevalence of diabetes in the US, the numbers that come to mind is 12% or something like that.
Well, wait till the
That's
NHANES
based
data.
on the whites who have 6%, right?
Right?
So the majority are white.
Exactly.
It's just.
And when you don't disaggregate the Asians, you get a mixed finding for the Asians too. So disaggregating data as finely as possible is so eye-opening. And our health systems, I don't know if PAMP does this, UCSF's doing a lousy job at collecting race ethnic data on patients. Kaiser's doing a lousy job. I just talked to Andy and everybody there. They're not collecting race ethnic data. So if we don't have the data, we won't be able to do interventions and find people at risk and intervene. And so
Because when you look at Kaiser data, the prevalence of South Asians comes so low, so I know in certain data this is not accurately done.
Because
they just
not
go into
self-
the big Asian and blah, blah, blah.
Exactly. And some administrative staff are coding people when they look at them and saying that they're this. And that's how it's been done. I mean, it's horrible, but that's the way it's, I don't know how else hospital does it, but we have to
We
improve.
changed it once we became a center to kind of code South Asians.
Good. It's only one word.
That's a
Okay.
big thing because in the hospital they would never track it that way.
That's right. I mean, we have to change our electronic health record systems to get this fine group disaggregation.
Even census data, all the census data that comes in, all the risk factors, all in one.
Yeah, so let's get our work done together here.
Okay.
So what about insulin resistance?
That's a side benefit
Yeah.
of polygenetic scoring, is that you know what the evidence is.
Yeah.
Precisely.
Yeah, I mean, you can get ancestry data because there's so much admixture in a lot of these populations as well. Anyway, so let's talk about insulin resistance. So in our non-diabetic population, the insulin resistance levels are highest among the South Asians, and the beta cell function, so the pancreatic cells that make insulin, there's the lowest levels of insulin are in South Asians too. So this kind of explains the rapid progression through pre-diabetes to diabetes as the beta cells are getting exhausted faster and there's more insulin resistance. So let's move on to CAC. You guys are here for CAC. Some people are here for CAC. Okay. So CAC is early in the process of atherosclerosis where you get calcification in the plaque.
CAC means in
Oh.
the room.
Okay. Coronary artery calcification is CAC. And so what happens is even in childhood or early adolescence, you can start developing atheromas. So these are lipid-filled plaques, which can have other inflammatory cell components. And then there's a calcified plaque that happens later in the process. And then the plaque can become vulnerable and rupture. And here you're seeing this material from the plaque go out. And that's when the platelets in the bloodstream, this is the lumen of the artery, the inside of the artery, the platelets stick to that ruptured plaque, causing a big thrombus or a clot, which impedes blood flow. And that's the whole process of a heart attack or a stroke. It's very similar in stroke unless you have a hemorrhagic stroke. So what we do with the CT scan is we look at this amount of calcium. So it's a marker of hardening of the arteries, that this person has a lot of atherosclerosis and it's kind of further down this process. And we do this by doing a CT scan with 42 cuts through the heart, and then there's software that white line showing up here in this artery is calcium, that's a speck of calcium, and we can score calcium, so the higher, the worse, right? And so this is data from our baseline exam 1 visit, men on the left, women on the right. South Asians are the red line, age 40 to 80 for both, different y-axes, and that's something you should know, that men always have more CAC than women. Women is 0 to 100. And the red line here and the green line, which is whites, track well together. There's no significant difference. And this is across the ages. You can see that they are quite high by 70 and 80. Whereas the other three groups in